Let's go to the inspection of the cardiovascular system. Inspection and palpation of cardiovascular system goes together. They are not watertight compartments. What you see on inspection, you immediately confirm by palpation. This is the ideal method of inspecting and palpating the cardiovascular system. The patient lies supine and the observer stands at the bedside foot end and see obliquely, tangentially. Also, you look obliquely and tangentially. You can also see at this time whether there is any pulsation in the left second intercostal space, are there any pulsation in the parasternal area, are there any pulsation in the aortic area, second right space, any epigastric pulsation and any suprasternal pulsation. You also inspect and palpate in the left lateral position where you can see and palpate the apex beat very clearly. The inspection and palpation is also done in sitting position, patient leaning forward, and in expiration you can see what is happening over here. At this point, you can also see whether there are any vessels here in between the scapula, so this position is taken for that purpose also. In selected circumstances, you do the inspection and palpation in standing position, sitting on a chair and in the squatting position as well. To start with, you examine the skeleton of the patient, position of the sternum. Some people you find the sternum is projecting outwards just like pectus excavatum, or it may be going inside as a cobbler's chest. Either pectus excavatum or carinatum, either way you may find that it can produce shift of the mediastinum in certain directions. And second thing, you look at the spine of the person. If there is kyphosis or scoliosis, that's a possible reason for shift of the apex beat, possibly the commonest cause. You look also at the spine, whether the spine is straight or not, in a situation called as straight back syndrome, where you find that the space between the sternum and the spine is very narrow. Commonly the thoracic spine is concave anteriorly, in straight and sternum is over here, and in straight back syndrome both become straight, the space for the heart becomes less, and so you may get some functional murmurs. You also look at the chest for any sulcus here, the lower end of the thorax, which is called as Harrison's sulcus. So sometimes you may find a person is not able to lie down without a pillow. That may give clue, possibly he is having ankylosing spondylitis, which can also have associated cardiovascular disease. Looking at the patient in general for skeleton, you may be able to say whether he is very tall like a Marfan, long fingers and limb span is more, which is suggestive of Marfan syndrome. These are some of the things you commonly look for in the skeleton of patients with cardiovascular system. Third thing is you look for scars on the chest wall. There may be a mid-sternotomy scar which indicates that possibly the patient had an open heart surgery, maybe bypass surgery or a valve replacement. There may be a lateral thoracotomy scar suggestive of a closed valvotomy. Just below the clavicle, you may find a scar of pacemaker insertion, and there may be a projection of underlying pacemaker. And if it's a defibrillator box, a bigger box may be seen bulging over there. If there is pacemaker or defibrillator box, try to separate the skin, remove it and see. If it's adherent to the skin, that means you have to reposition it. If the skin is eroded, that indicates that you have to replace it. So examination for scars is very, very important, and you may sometimes see drainage of the pericardial effusion and so on over the chest wall. We also commonly look for veins on the chest wall. Veins on the chest wall may be because the skin is very transparent. You may be able to see the blue lines of the veins. Sometimes you may find very tortuous veins of superior or inferior vena cava obstruction. You may also find sometimes tender cord-like veins are palpable over the chest wall, crossing the rib margin because of thrombosis of the superficial veins called as Monroe's disease. The commonest presentation of Monroe's disease is chest pain. By just palpating the skin and looking for the venous thrombosis, you will be able to pinpoint the diagnosis and further investigations can be avoided. Looking for the pulsations of the veins, you also look for anything. Pulsations of the artery, in between the scapula, you may find pulsatile collaterals in case of quarters of aorta, which is called as Sussman's sign. Also look for any swelling on the rib. There may be costochondritis or teeth syndrome can be easily detected by palpating the costochondral junctions. Here again, the patient says, I have got chest pain. Next thing is to look for apex beat. Apex beat represents left ventricle. So when you inspect and palpate cardiovascular system, you are concentrating on different anatomical structures of cardiovascular system. Apex beat represents the left ventricle. The parasternal area represents the right ventricle. Left secondary costal space represents the pulmonary artery. Right secondary costal space represents the aorta. So these are the important structures you are specifically concentrating for. Then of course you are concentrating for aorta as such, which can be indirectly seen in the epigastrium, suprasternal region, or the sternoclavicular joint, or over the manubrium. Coming to the apex beat. Apex beat is the lowermost and outermost point in the precordium where a distinct impulse can be seen. Which is the best position to look for apex beat? Apex beat can be seen like this, and the patient is lying supine. If there is a difficulty to locate the apex beat, here you can see the apex beat clearly. But if there is any difficulty to locate the apex beat, it is at that time you just tilt the patient to the left lateral position. By that you can easily find out the character of the apex beat. By tilting the patient to the left side, possibly the apex beat shifts to the left side, so you cannot localize the site, but other features of apex beat can be easily found out. What all things you look for when you look for apex beat? First, the site of the apex beat. For this purpose, we have some imaginary lines of the cardiovascular system. This is the midline, and this line in the midpoint of the clavicle is the midclavicular line, and the point where the anterior axillary fold touches the chest wall, and a line vertically drawn downwards is the anterior axillary line. A line drawn from the posterior axillary fold where it touches the chest wall is the posterior axillary line, and this is the mid-axillary line. So we have these lines, and we can always describe the findings in relation to these imaginary lines. Now, apex beat is classically at 9 centimeters from the midline or 1 centimeter inside the mid-clavicular line. What are situations where you may not be able to see or feel in apex beat? Apex beat may not be seen or felt if it is on the right side, dextrocardia. If the patient is very obese, very emphysematous, COPD, or if the apex beat is under a rib. So there are situations where apex beat may not be seen. Now the apex beat site may be displaced. Important points are: 1. The commonest cause of displacement of apex beat is spinal deformity. Always check for it. 2. Apex beat is shifted by disease of the mediastinum or the lungs or pleura. Pleural effusion, pneumothorax, collapse all shift the apex beat in different directions. It may be pushing to the apex beat to the left side or pulling to the right side. So that once the spinal diseases and respiratory diseases are ruled out, shift of the apex beat is because of cardiovascular system disease. The commonest site is a fifth space, 1 centimeter inside the midclavicular line. If this space is displaced outwards, that means there is a right ventricular enlargement. On the other hand, if the apex beat is displaced downwards and outwards, that indicates that possibly there is a left ventricular hypertrophy. So just shifting outwards is right ventricular hypertrophy, just pushing it downwards is left ventricular hypertrophy. So site of the apex beat is very important. 2. What is size of the apex beat? Normally apex beat is very small point, less than 2.5 centimeter in size, confined to one particular space. The apex beat is produced by the apex of the left ventricle in the counterclockwise movement of the heart, and it takes place in the early part of systole. So it is isovolumetric contraction. At that point you get the feeling of apex beat. So the size of the apex beat is very important. If apex beat is diffuse, that means there is very gross disease of the myocardium like cardiomyopathy, severe heart failure, or aortic regurgitation. So site of the apex is important, site of the apex is important. Now what is the character of the apex beat? Normal apex is very brief, and it will not cross more than 1/3 of systole, maximum 50% of systole. The apex beat comes down by that time. The upward lift of the finger or the feeling you get for apex beat is over in the 1/3 of systole. If it is sustained more than that, that is very important. So there are different characters of apex beat. 4 different characters require special attention. Number 1, tapping apex. Tapping apex is defined as a momentary and feeble apex. That's the definition, momentary and feeble apex. 2, mechanism of this apex is by feeling of the first heart sound. It's a palpable first heart sound because it's very, very loud. And what's the inference? This patient has got mitral stenosis. The second type of apex beat is what is called as forceful apex beat. Forceful means when you palpate the apex beat, your finger is lifted above the adjoining ribs. When the finger is lifted above the adjoining ribs and it is not sustained but suddenly comes down within 50% of systole, you call it as forceful type of apex. That indicates it is a diastolic overload, it is a volume overload, commonly seen in aortic regurgitation and mitral regurgitation. The third type of apex beat is an apex beat that lifts your finger above the adjoining ribs, but it is sustained and it goes more than 1/3 to 2/3 of systole. This type of sustained apex beat that is lifting your finger above the adjoining ribs is called as heaving apex, and that indicates a pressure overload, systolic overload, commonly seen in hypertension, aortic stenosis, hypertrophic obstructive cardiomyopathy. So I have given 3 different types of apex now. I said tapping, definition, mechanism, and the cause. 2, forceful, definition, mechanism, and the reason. Heaving, definition, mechanism, and the causes. The 4th type of apex is what you get in case of when you feel, you find a double, 2 apexes can be felt. That's because either the patient has got hypertrophic obstructive cardiomyopathy or patient is having what is called as ventricular aneurysm. One part of the ventricle is contracting, other part is bulging, like CSO apex. So you get double apex. Commonly apex beat is single. The 4th thing you look for is a thrill over the apex beat. Now what is the technique of palpating the apex beat? Normally you put a whole hand on the chest wall, and where you get pulsation, you put your one finger and just define the apex beat. Now in this position you can feel a thrill is coming with the apex beat or preceding the apex beat. If it comes with the apex beat, it is systolic. If it comes earlier, it is diastolic. You can always tilt the patient to left side to get the thrill. So by tilting the patient to left side, you are looking at the character of the apex beat, whether the thrill is palpable or not. And in this position, by just looking obliquely, you may be able to see whether there is a 3rd sound or 4th sound which may be visible or it may be palpable. So coming to the apex beat, we have gone to the different aspects of apex beat. You have seen the size, you have seen the causes of displacement, character. So summarizing the apex beat as such, we are looking at the site, size, character, whether single or not, with associated thrill or not. These are the important things you look for when you look at the apex beat. Now, apex beat gives you a clue regarding the status of left ventricle. We are going to study the status of right ventricle. In the anatomy, you would have learned that this part of the anterior part of the chest is occupied by the right ventricle, only strip on the left side is by left ventricle. So, right ventricle is occupying the area just behind the sternum. So, you are looking for pulsations of this area that represent the right ventricle, and then you can feel for the right ventricle pulsation just outside the sternum, parasternal area, and see whether you can feel a lift or not, called parasternal lift. You may also put your finger like this or your palm like this and see whether there are pulsations. So, this is for studying of right ventricular hypertrophy. So, parasternal heave indicates right ventricle is hypertrophied, and right ventricle is hypertrophied, you get a lift. Rarely at the end of systole you may find you may get a pulsation or a lift in severe mitral regurgitation, because just behind the right ventricle is situated the left atria. So, if there is a mitral regurgitation, the whole blood from the left ventricle is pumped to left atria because the valve is incompetent, and you may get a delayed left parasternal heave. When you palpate, if you get a thrill over this area, third space and fourth space parasternally, then we are thinking about what is called as VSD. The parasternal heave can occur in all situations where there is right ventricular hypertrophy, starting with mitral stenosis, pulmonary stenosis, any cause of pulmonary hypertension, idiopathic pulmonary hypertension, Eisenmenger syndrome, and so on. After studying the right ventricle, you can go to study the pulmonary artery. Pulmonary artery is situated in the second left intercostal space, which you can identify with the help of angle of Louis. And looking at the pulmonary artery, you look for pulsation. If there is pulsation, that means pulmonary artery is dilated. Pulmonary artery dilates if there is increased pressure or increased volume, or there may be idiopathic dilatation of pulmonary artery. Rarely, very rarely, even in pulmonary stenosis, there may be post-stenotic dilatation which may produce a pulsation. You may also palpate the left second intercostal space, previously called as pulmonary area, and what all things you look for here is there a pulsation? 2, is there palpable sound? The sound that is palpated in the second left intercostal space is P2, component of the second heart sound, and you may also get a thrill over this area. The common cause of thrill in the pulmonary area: number 1, pulmonary stenosis; number 2, ASD; number 3 is patent ductus arteriosus, when the pulmonary hypertension slowly is developing and systolic component is taken off. Then you are going to palpate and see the aorta. The aortic valve is commonly represented at the right intercostal space second side. Once again, demonstrating how to look for the aortic pulsation, you make the patient lean forward, you palpate the aortic area with your palm, ask the patient to expire out and hold. At that position, you may get a thrill of aortic stenosis. And if there is a thrill, always compare the carotid also, there may be a thrill going that side. Okay. Now we are going to see the pulsation of aorta as such. What are the pulsations of aorta? Aorta may be undergoing what's called a aneurysmal change, where if the ascending aorta is having aneurysm, you may get pulsation of the right sternoclavicular joint or right side sternum. Pulsation also be obtained if there is right sided aortic arch. If the arch of the aorta is having aneurysm, the manubrium itself may be pulsating, and left sternoclavicular joint may pulsate if there is aortic aneurysm. The aortic pulsation may be also seen in other areas, but these are areas specifically look for aortic aneurysm. Now we are going to study the epigastrium. Is there an epigastric pulsation? If there is epigastric pulsation, it may be from the right ventricle or from the aorta. To differentiate between them, you put your finger just below the sternum, push upwards and see what is happening. If the pulsation is coming from above, it will touch your tip, that is right ventricle. If it is touching your pulp, that is aortic pulsation, and rarely any swelling, lump over the aorta may produce a pulsation. Thin people, nervous people who are excited, epigastric pulsation is common. Inspection of cardiovascular system, palpation also includes inspection palpation of the suprasternal area, unfolded aorta, aortic aneurysm, systemic hypertension may produce a pulsation over there. And if the aortic regurgitation very severe, you may get corrigant pulse, very pulsatile carotid may be seen from a distance. When you inspect and palpate CVS, cardiovascular system, you actually palpate all over the precordium, and all areas called as ectopic areas also needs to be palpated for any event at all. Okay. Now, specifically looking for third heart sound, fourth heart sound, you have to put the patient left lateral position, and here you can see and feel third and fourth sound. The basic principle of cardiovascular system is outward pulsations are better felt, inward pulsations are better seen. Third heart sound, fourth heart sound are inward pulsations. They are better seen than felt, better felt than heard. So when you auscultate, it may be difficult to get it. Palpation you may get, inspection still it may be easier. So even if you don't get palpation, you may be able to see. So if it is a fourth heart sound, there's apex beat. Just before the apex beat, there will be a small notch coming up, small wave, that is the S4. Similarly, if the apex beat is over, then you get another one, it is S3. So you just inspect whether it's apex beat, before there's any pulsation, and after that also you can palpate for that. In phalangostetrology, we don't expect parasternal heave usually, and if a heave is present, that rules out the possibility of tricuspid atresia. Coming to the percussion of the cardiovascular system. Percussion is the least important in the examination of cardiovascular system examination. First, we will discuss the technique. You have to delineate the border of the right side and left side. For right side, you start percussion from the top. You keep on percussing, comes down to the upper border of the liver surface. Once you have found out the liver, just space above that, you percuss for the cardiac dullness. So your finger has to be kept parallel to the heart, and you percuss like this. And should be very light percussion till you get the right border. Similarly, when you feel for the left border of the heart, first you feel the apex, and then you have to percuss lightly and come like this and find out left border. What's the importance of percussion of heart in cardiovascular system? The only diagnosis you can make is by pericardial effusion. If you find the size is large and there is dullness outside the apex beat, that means there is pericardial effusion. The cardiac dullness may also be obliterated in case of emphysema in people who smokes a lot and people suffering with chronic obstructive pulmonary disease. The auscultation is by using a stethoscope. We are expected to have a diaphragm and bell, and diaphragm for high pitched sounds, bell for low pitched sounds. So auscultation is a difficult art, and it can be learned only by repeated attempts to auscultate. Basic principle of auscultation is always concentrate for the event you want to hear. If you want to hear for first heart sound, you focus for that. You want to hear second sound, you focus for that. You want to hear third sound, fourth sound, focus for that. Similarly, for opening snap, diastolic murmurs, clicks, and systolic murmurs. Any event you want to hear, you have to focus it. If you auscultate for a long time in a particular area continuously, you are not likely to hear anything new. More than 4 cardiac cycles may be commonly useless for you. So brief auscultation is the best for everyone. Now, the commonest error, mistake students make is difficulty to identify systolic and diastolic. they just auscultate their systolic murmur or a diastolic murmur without timing. They forget to time and systolic becomes diastole and vice versa. So basic principle is whenever you auscultate, your thumb should be on the carotid. Left thumb on the right carotid. That's how you auscultate, and it corresponds with the first heart sound. Events preceding that is diastolic, coming with that is systolic. This is easy method by which you can easily auscultate these patients. Now, what's the best position to auscultate these patients? This is a common position, supine position, where you auscultate all the patients. Number 2, always make sure you put the patient left lateral position and auscultate with the both bell and the diaphragm in that position. You also make the patient sit up and auscultate in expiration. Patient hold the breath in expiration and you auscultate. In special circumstances, you make the patient sit up, stand up, squat and do isometric, what is called isometric hand grip examination. So these are steps called dynamic auscultation. So commonly in supine position, you auscultate with the diaphragm, you auscultate with the bell, and left lateral position with the bell also, sitting position leaning forward in expiration, specifically for right second intercostal space. Which are the areas commonly you auscultate? Over the apex. Wherever the apex is, that's the first site to be auscultated. You can start auscultation from any area to start with, maybe from second right space, left space, anywhere. But all areas must be auscultated. You may go for apex, then you may go for lower sternal area where you get events of tricuspid valve. Apex, you get events of mitral valve. Then you go to the left second intercostal space, we get pulmonary events. Right second intercostal space, you get events of the right aorta. And third and fourth spaces, you have two things there. One is events of ventricular septal defect and Levine's area 2, second aortic area, third and fourth space. These are important areas for us to be auscultated. Third and fourth space in the left side for ventricular septal defect, third space for the aortic murmurs. So important steps are position of the patient, your equipment, timing of systole versus diastole. We go to the auscultation and we start with the apex for first heart sound. So first heart sound has got two components, mitral and tricuspid sounds. Put your thumb on the carotid. So there are two components for first heart sound. Mitral component comes first, tricuspid component follows. The important point is mitral component is heard all over the precordium, and first heart sound is always auscultated over the apex and the lower sternal area. Second heart sound you auscultate over the base of the heart. So events of first heart sound is best heard over this area, apex and left parasternal area. The mitral component is heard all over, but tricuspid component is heard only over the tricuspid area. So if you get a split first heart sound in tricuspid area, that is normal for a human being because there is asynchronous closure between mitral and tricuspid valve. And over the apex, you will get only single sound, that's the mitral component. Now when you hear the first heart sound, immediately you ask what all things I should look for. Now, first thing, the sound. Is it loud, normally loud, or very loud, or is it muffled? So what decides the intensity of first heart sound? Intensity of first heart sound depends upon, one, the heart rate. Heart rate goes up, diastole becomes less, so you will find that the sound becomes wider. PR interval goes up, you find it becomes more. So heart rate and PR interval can decide the intensity of first heart sound. More important is position of the valve when the ventricle is contracting. Imagine two situations. This is a mitral valve almost closed and ventricle is contracting, it will produce sound like this. Imagine a valve which is maximally opened and the ventricle is contracting, and you will find a bigger sound is produced. So, interpolating what we already said, we extrapolate the data we already said, short PR interval, heart rate is increased. In increased heart rate, by the time ventricle is contracting, valve is maximally opened. Diastole is very short, you get a loud sound. In diastole, if it is very long, like bradycardia, you find by the time the ventricle is contracting, valve is automatically closed almost, a small sound is produced. So, position of the valve is important. Next thing is structure of the valve. If the valve is pliable, you get normal sound. But if your valve is fibrosed or calcified, the sound will become dampened, muffled. So, first heart sound can be increased, can decreased depending upon these factors. Now, first heart sound usually constant, does not change from person to person or from beat to beat. If you find the first heart sound is keeping on changing intensity, something wrong with this patient. Maybe he is having multiple extrasystoles, or maybe he has some arrhythmia like atrial fibrillation. Complete heart block is another situation where first heart sound may vary in intensity. So, first heart sound variability is very important. Now, what are situations where the split can be very wide in first heart sound? If the first mitral component comes early, as in mitral regurgitation, or the tricuspid component comes late because of a conduction defect to the right side, you find that the interval between mitral and tricuspid component can be variable. All heart sounds will be muffled whenever there is emphysema or pericardial effusion. So, when you look for first heart sound, specifically for the apex and the tricuspid area, look for the intensity, look whether it is constant or is it variable intensity. Now, if you get arrhythmias like Van Gieback phenomenon, where PR interval is progressively increasing in duration, you will find progressively the first heart sound becomes less till a drop occurs. That is also possible for another mechanism for changing first heart sound. Now, look at the second heart sound. It has got two components, A2 and P2. So, you are auscultating at the left and right second intercostal spaces. The first component is aortic, second component is the pulmonary. So, auscultating our left second intercostal space, previously called pulmonary area, you find the aortic component comes first, then pulmonary component. Normally, you get a split. That is normal, physiological. As a patient takes deep breath, the right ventricle gets more blood, so slowly the pulmonary component becomes delayed. So, there will be some respiratory variation with inspiration for this split. Just like we said, tricuspid component of the first heart sound is heard only here. Pulmonary component is commonly heard only over the pulmonary area or second left intercostal space. If it is heard the same intensity as A2, lower down over the apex, you say P2 is very, very loud. Now, what are the situations where P2 is loud? Is it in pulmonary hypertension? And which situation A2 becomes very loud? Systemic hypertension. Which situation A2 becomes absent? In aortic valvular stenosis. And which situation P2 becomes absent is when there is pulmonary stenosis. Now, comes to the split of the second heart sound. Normally, there is a split. That's because of excess blood flowing to the right side during inspiration, and events of the right side becomes delayed. In scenarios like atrial septal defect, where the hole in the atria makes both left and right ventricle a single chamber, you may find that it's a common chamber, right to left difference is not there. So, there is no respiratory variation of this second sound split, and this is called as fixed wide split of atrial septal defect. Commonly, during inspiration, A2 and P2 separates and split becomes wider. In expiration, it becomes closer. Imagine a situation where you find the A2 comes delayed, maybe because of left bundle branch block or severe aortic stenosis. Left side is pumping blood very slowly. So A2 becomes more delayed. In such situations, you may find the split is best heard in expiration, because in expiration you find that the P2 is coming forward and A2 is getting more and more delayed. So you get what is called as reversed splitting. So reversed splitting occur whenever the split is present during expiration, not in inspiration, and this occurs in severe aortic stenosis, left bundle branch block, or when there is a right ventricular pacing. So analysis of second heart sound is very, very important. S3 occur during diastole and it occur during the rapid ventricular filling time. Best seen than felt, better felt than seen. So when you get a third heart sound, what does it mean to us? It means that if the patient is less than 40 years old, it does not mean anything. So S3 may be normal in a normal person. After age of 40, or in people who are very symptomatic, the other signs, S3 may be important for us. There are two scenarios where you have to imagine. S3 occur when there is increased amount of left ventricular and diastolic pressure, volume, producing heart failure. So in pressure overload situations, presence of S3 indicates heart failure. In volume overload situations like mitral regurgitation, aortic regurgitation, presence of S3 does not mean it is a heart failure. It may indicate only the severity of the disease. So S3 does not mean disease in young people, and S3 is normal for mitral regurgitation, aortic regurgitation. Now transiently S3 may be heard during acute myocardial infarction or during angina pectoris. So S3 can be normal also. Where do you look for S3? S3 look for apex for left ventricular S3, and patient is in the left lateral position and you are using your bell to hear it. Just ഒന്ന് തിരിഞ്ഞു കിടക്കുക. Okay, always compare with the carotid, and bell must be applied very gently. The impression of the bell should not come on the skin. If it comes on the skin, it becomes very tight and acts like a diaphragm. So if you want to hear right ventricular S3, you have to auscultate over the lower sternal area, also called as tricuspid areas. When we say areas, we refer to mitral, tricuspid, pulmonary and aortic area, because the events from these valves are best heard there. These days these terms are not used because there can be some mistakes coming here and there, because murmur of mitral regurgitation sometimes heard all over the body, or the spine, back, or aortic area, and aortic murmurs may be better heard in the mitral area rather than the aortic area, so mistakes can come. That's why we are using the term apex, left lower parasternal area, left second space and right second space. So left ventricular S3 and right ventricular S3. Coming to the S4. S4 comes just before the first heart sound. So sometimes you may think it's a split first heart sound. S4 is better seen than felt, better felt than seen. Just like S3, you use your bell, left lateral position, and auscultate, feel and look for S4. What does S4 indicates? S4 occur because of atrial contraction. So any situation where atria is contracting against a non-compliant ventricle, which are refusing to accept blood but resist, you get S4. So atrial fibrillation, it disappears. S4 is always an abnormal finding. It means that left ventricle is at fault, and you may get S4 whenever the left ventricular end diastolic pressure is high, or there is poor compliance of the left ventricle. Systemic hypertension, hypertrophic cardiomyopathy, common situations where S4 is commonly heard. The S4 and S1. S4 can change with the maneuvers, it increases the venous return. S1 does not change. So in difficult situations, that's how we differentiate between the two. The events in systole, other events in systole, number one is click. Clicks are high-pitched sounds you hear during the systole of the heart. The systolic clicks can be divided into ejection click and non-ejection click. Ejection click occur during the early part of systole. Usually within the first 1/3 of systole you get ejection click. Ejection click again occur from aorta or pulmonary valves. So ejection click over the aorta and pulmonary valve, they look alike, they hear alike, sound alike. The difference is the aortic ejection click is heard all over the precordium, one, and pulmonary click is localized to the pulmonary area. Number two, unlike murmurs, pulmonary click increases on expiration, decreases on inspiration, and aortic click does not vary with that. So points to differentiate between aortic click and pulmonary click is the site where it is heard and the respiratory variation. Now when do you get aortic click? Aortic click commonly you get in valvular aortic stenosis, when the valve is pliable. Subsequently, as the valve becomes thick, fibrosed and calcified, the click disappears. So a person who is coming for a follow-up, if click was present earlier, the click has disappeared now, that means the stenosis has progressed. Coming to the pulmonary ejection click, you can get in valvular pulmonary stenosis. Pulmonary click can be heard whenever this pulmonary artery is dilated, idiopathic dilatation, or even in pulmonary hypertension. So ejection click of pulmonary and aortic valve. Now comes entity called as non-ejection clicks. As the term indicates, non-ejection clicks come in the late part of systole, not during ejection. They are classically heard when there is a mitral or tricuspid valve prolapse. And these sounds are better heard over the apex or the lower sternal area. During the systole, we may get systolic murmurs. Whenever murmur is rough, that indicates turbulence and stenosed valve. So you may get a systolic murmur. Systolic murmur can be looked according to the time when it is heard. During ejection part, ejection systolic murmur. Ejection systolic murmurs start with the ejection, and it has got a peak and takes a diamond shape, crescendo decrescendo murmur. Second type of murmur in systole is holosystolic, pansystolic murmur. Start with the first sound and the intensity and the quality remains same throughout the systole and end with the second sound only, pansystolic murmur. The third thing is murmurs occurring late part of systole and ending with the second sound. They are called as late systolic murmurs. These are three types of murmurs in systole commonly you get. When you get a murmur, first question, where is the murmur? If you get a systolic murmur, the aortic area, right second space, and if it's radiating to the carotid, you know it is the aortic stenosis. If it is coming in the left intercostal space, going to supraclavicular area, you know it is pulmonary stenosis. The site gives a clue that is what is the diagnosis. If you get a pansystolic murmur of the apex radiating to the axilla, you know it is a mitral regurgitation murmur. If you get a murmur, lower sternal area, pansystolic murmur, increasing on inspiration, you know it is tricuspid regurgitation murmur. Exceptions are there. As we already said, mitral regurgitation can be heard all over. Aortic regurgitation murmur may be heard over the apex. Otherwise, these murmurs are all localized murmurs. So, where is the murmur heard? Number two, what's the intensity of the murmur? Intensity of the murmur has nothing to do with the severity. Very small ventricular septal defect can produce very intense murmur. That does not mean anything. Very large ESD may not produce a loud murmur. So, intensity does not mean anything. but still it is classified according to Levine system. Systolic murmurs are graded into 6. Grade 1, heard with difficulty. Grade 4, you can feel a thrill. Grade 6, even without stethoscope, you can hear the murmur. So grading can also be done. What's the quality of the murmur? Is it soft, musical, or is it rough? 3. What is the variation of the respiration? Those arise from the right side like tricuspid regurgitation murmur, increasing on expiration, and aortic murmurs, tricuspid murmurs increasing on inspiration, tricuspid murmurs increasing on expiration. So systolic murmurs can be according to timing, ejection, pansystolic, or can be asystolic. And if it's a thrill, you say it's grade 4. What is the relation with the respiration? Then look, where does it conduct to? A murmur in the right second space conduct to the carotid is aortic stenosis. Murmur on the left intercostal space conduct to supraclavicular area is the pulmonary stenosis. A murmur on the apex conduct to the axilla is mitral regurgitation. A systolic murmur or the tricuspid area increasing on inspiration without any conduction is always a tricuspid regurgitation. And in between third and fourth space, if you get a pansystolic murmur, that is murmur of ventricular septal defect. So you have to look at the murmur from different direction. What is site? What is the type of murmur, timing? Where does it go to? And what's the change of respiration? Okay. You also look at the dynamic changes, change the respiration and other dynamic maneuvers when you have a systolic murmur. Systolic murmurs can be heard in simple anemia, pregnancy, thyrotoxicosis, or situation where there is hyperdynamic circulatory status. So how to differentiate between functional murmurs and organic murmurs? Functional murmurs are always systolic. Functional murmurs are not diastolic. They are not continuous. They are faint murmurs, never with a thrill. They are heard only in the bases, not elsewhere. So certain rules are there. 2 golden rules. Number 1, if a person has got a systolic murmur, assess him according to his accompaniments or companions. As you assess an individual based upon his friends and accompaniments, you can say murmur is significant or not. If he has got symptoms, if he has got difficulties of some defect of his pulse, blood pressure, JVP, other findings, ECG findings, X-ray findings, murmur may be significant. If everything is normal, systolic murmur may be ignored. Number 2, you look at the S2. Organic murmurs, S2 will always be abnormal. The 2 murmurs here is aortic stenosis and pulmonary stenosis. In both situations, S2 is attenuated, dampened. So S2 is the next important thing. Now there are 3 golden rules. The golden rules are: diastolic murmurs are never organic, continuous murmurs are rarely organic. So the 3 silver rules are: all pansystolic murmurs are again organic murmurs, they are not functional murmurs. So functional murmurs usually occur during the ejection systolic period. So whenever there is systolic murmur, you need to assess whether this patient is having functional murmur or organic murmur. So we have gone through different parts of the systolic murmur. Now comes the question, whenever there is a systolic murmur, it may be from mitral valve prolapse or hypertrophic obstructive cardiomyopathy. In this situation, we have certain maneuvers during auscultation. We will show the maneuvers first. First is, we will do the Valsalva. We ask the patient to close the nose and close the mouth and try to exhale. So this is sometimes difficult for the patients. So you ask him to strain against my hand. That means he is distending his abdomen and trying to push. Keep it there. This is Valsalva maneuver. Second thing is, you do him auscultate when he is making a closed tight fist and see the change. എണീറ്റിരിക്കൂ, കാല് തൂക്കിയിട്ടിരുന്നോ, കാല് തൂക്കിയിട്ടിരുന്നോ, ഇങ്ങോട്ട്. So I am auscultating him in this position and see what is happening. എണീറ്റിരുന്നേ. Next thing is you ask him to stand up and you continue to auscultate. Last thing is the squatting. He is squatting and we are seeing the change with position. Whenever this patient squats, what we find is his peripheral vascular resistance increases, return to the ventricle becomes more, so ventricle becomes larger. When ventricle becomes larger, the mitral valve does not prolapse as much as when the ventricular size is small. Similarly, when ventricular size becomes larger, in hypertrophic obstetric cardiomyopathy, when it becomes larger, the obstruction to the outflow tract becomes less. So basic principle is to increase and decrease the size of the left ventricle. Accordingly, whenever the ventricular size is small, obstruction by obstetric cardiomyopathy and prolapse of the mitral valve will increase. So this is a scenario commonly used to differentiate between other systolic murmurs and murmur of obstetric cardiomyopathy and mitral valve prolapse. Now, what are the common events in diastole? Diastole, we specifically look for opening snap. Opening snap takes place whenever the mitral valve suddenly stretched and open and you get snapping sound like this. So this is how opening snap is heard commonly. And where do you look for opening snap? Not over the apex, just inside, closest to the sternum. At that point, opening snaps are better heard. What's the importance of opening snap? Opening snap is heard during diastole, and with opening snap, mid-diastolic rumble may start. And opening snap is seen only if the mitral valve is pliable, then only you can hear the sound. So this sound disappears as mitral valve becomes fibrosed, calcified or thickened. Again, the timing of opening snap in relation to A2 component of the first heart sound is important. A2 component is important because opening snap coming early means the pressure in the atria is higher, indicates severe stenosis. So closer to the second heart sound, severe the stenosis. So three things are there, pliability, 1, 2, and indication of the severity, 3, disappearance of already existing opening snap indicates it has progressed further from there. Then we are going to auscultate for diastolic murmurs. Diastolic murmurs can be again early diastolic, mid diastolic and late diastolic are called pre-systolic accentuation. So early diastolic murmur occur whenever valves become incompetent. So two valves which become incompetent producing diastolic murmurs, one aortic regurgitation murmur and second is pulmonary regurgitation murmur. Aortic regurgitation murmurs are commonly auscultated right second intercostal space and you can hear the murmur. When you go to the third left intercostal space, again you can hear the murmur. And it again. Patient is leaning forward in expiration and is holding breath. I can hear the early diastolic murmur. Alternatively, I can hear also. It's very essential to find out where exactly the murmur is better heard. If the aortic root is dilated, because of that there is regurgitation, the murmur is commonly heard here. Because murmurs are commonly heard along direction of flow. If, on the other hand, the valve is in trouble, not the root, you find the murmur is better heard over the left side of the sternum. So timing is important for us. These murmurs are maximum to start with, second sound, and slowly it goes down. Decrescendo murmur. decrescent of murmurs, going down in intensity, and it disappears. The duration of that murmur also depends upon severity. If it extends longer, that means aortic regurgitation murmur is very severe, regurgitation is very severe. Similarly, pulmonary regurgitation murmurs are commonly heard over the pulmonary area, and it may be just after P2, not after A2. That is heard in pulmonary regurgitation. Now coming to the mid-diastolic murmurs. Two mid-diastolic murmurs requires attention. One is over the apex and other one is over the tricuspid area. If you find a mid-diastolic murmur over the tricuspid area, it is commonly because of a tricuspid stenosis, which is very, very rare, and it's always organic. And when you get a murmur of mitral regurgitation, commonly it is mid-diastolic murmur, best heard with the bell of the stethoscope. So when the murmur is low pitched, always use your bell, and if the murmur is high pitched, use your diaphragm. That's the basic rule. And this murmur is usually very turbulent, rough, and rumbling in murmur. And whenever you have this type of mid-diastolic murmur of mitral stenosis, try to find out how long it is, because mild mitral stenosis produce very brief mid-diastolic murmur, but if the murmur becomes very long, that means the stenosis was very, very severe. That's the importance of knowing the duration of the mid-diastolic murmur. Then comes the late diastolic murmur or pre-systolic accentuation. That's what we get in atrial fibrillation. Whenever the atria fails to contract, the pre-systolic accentuation cannot occur. So that disappears. So in mitral stenosis patients, early part, the blood flows across the mitral wall, you get a mid-diastolic murmur, and later you get the boost of the contraction of the left atria, producing the pre-systolic accentuation, which disappears as atrial fibrillation ensues. These are the three diastolic murmurs you have to specifically look for. The last type of murmur you get in auscultation is a continuous murmur. Continuous murmur is defined as murmur that starts in systole and cross over the second sound to diastole. Commonly it is indicative of an organic disease like patent ductus arteriosus, rupture of sinus of valsalva, arteriovenous fistulas, and so on. Rarely, in cases of venous hum also, you may get a continuous murmur. So continuous murmur starts in systole, crosses second sound to diastole. It need not fill both cycles of systole and diastole. Important point is crossing the second sound to diastole. Physiological situations like a lactating mother or a pregnant person can have a souffle, murmur is souffle. It can also mimic a continuous murmur. So coming to the venous hum, couple of points are there. It is commonly heard over the root of the neck. You auscultate, you hear a continuous. So, and this murmur is continuous, increasing on inspiration. When the patient turns head to the opposite side, venous hum increases. When the patient turns to the same side, it decreases, and it increases and becomes peak at the end of inspiration. And becomes less when the patient lies down, become maximum when the patient sits up. And when you put a finger just above the clavicle, the venous flow decreases, stops, and venous hum stops. So venous hum is a continuous murmur, heard better in the sitting position, less in lying position, best in inspiration, maximum at the beginning of inspiration only, and then turning the head to either side, you can change. Rarely it is palpable. It's commonly seen in anemia, rarely in thyrotoxicosis and pregnancy. The last type of event you may hear sometimes in patients with viral diseases is pericarditis and pericardial rub. May be very commonly seen in patients with pericarditis due to kidney diseases. Also in the ward you may find pericarditis. Pericarditis may be commonly seen following myocardial infarction. So pericarditis is not very rare. It can mimic a murmur. So pericardial pain, patient usually say pericardial pain over here radiated to the superior margin of the trapezius. And when you auscultate, you take special precaution to not to miss it with systolic and diastolic murmurs. It has three phases of pericardial rub, and pericardial rub is best appreciated when the patient sits up and in this position little more. Okay, auscultation, you may find pericardial rub becomes very easy to hear. So these are the important points regarding auscultation of the heart. So pericardial rub has got three phases. There's a triphasic extrasound, and it's best elicited when the patient leans forward and you auscultate with your diaphragm. It's very essential to differentiate between a pericardial rub and a murmur, and also a presence of pericardial rub may always give a clue whether a kidney disease patient needs dialysis or not. The detection of this should not be missed. Thank you.